Dr. Abhijit Wadiyaram.
Today I'm here to
Niraj,
present
come here please.
our technique and philosophies in vertebroplasty and augmented screws. I thank organizers of SMISS AP in Mumbai, Dr. Arvind Kulkarni and Ayush Sharma for giving me this opportunity to present our work. As we all know, the most important thing starts with the patient selection in any surgical technique. For vertebroplasty or an augmented screw, the indications would be painful osteoporotic vertebral compression fracture. It could be acute or chronic, which you can identify according to T1 hypo, stir positive on MRI indicating marrow edema. Kummel sign is one of the first sign or the best sign which indicates intravertebral fluid, pseudoarthrosis and also intravertebral instability. This is a representative case where you can see that there is L2 compression fracture. You can see MRI shows stir positive and marrow edema which is present. We'll go through the technique. First and foremost, once you position the patient on the table, make sure that you obtain as much as possible true AP and true lateral of the image. Sometimes in an osteoporotic patient or a high BMI patient, obtaining this true AP and true lateral, especially at the fracture level, might be difficult. Try to achieve as nice pedicle as you can see in our patient, as which is visible here. You can see this pedicle is nicely visible at a compression fracture. You have to be sure that in lateral your posterior margin is appearing as one line and not the oblique one, so that if at all your cements are leaking posteriorly, you are very sure that where your cement is going. Then once you have positioned the patient prone, I always position the patient on a bolster, so that first, because of the positioning, your patient will have some kind of opening of the compression fracture. Try to compress the patient posteriorly at the spinous process to see if your patient's fracture is opening up or not. If that is happening, that will give a positional reduction in your patient, and that positional reduction itself will give some kind of height restoration. As you can see in this image that just by compressing you can achieve a very good height restoration in this patient. Then the next is standard technique for vertebroplasty. You start from 9 o'clock position on a left pedicle, go till the medial border of the pedicle. When you enter at the medial border of the pedicle, your needle should be at the base of the pedicle in lateral, and then finally you inject the needle into the compressed fracture. As you can see, this is the needle which starts from 9 o'clock and just enters the pedicle. At the same time in lateral it is entering the pedicle. When it reaches the medial border of the pedicle, the needle is at the base of the pedicle in lateral, and this needle is into the compressed area, or this is an early Kummel sign. Now I always insert this guide wire from the needle just to check the integrity of ALL or the anterior cortex, just to make sure that my cement would not leak and my needle is absolutely within the osseous confinement of the vertebra. So do check before you start injecting the cement. Once that is done, you can see that gradually well prepared cement is injected into the compressed fracture, while my assistant is applying compression or the pressure on the spinous process of the patient to achieve positional height restoration. You can see that cement is going very well, and cement has gone from mediolateral and entirely filling the void inside the vertebra. Now you can use single needle or a double needle technique as per your comfort. I am quite comfortable using a single needle technique in our patients. This is the video depiction. You can see that I am injecting, putting the needle. This is done under local anesthesia, or you can do under general anesthesia. Over a period of time, I have learned to do this technique as much as possible into general anesthesia, because sometimes when you are injecting the patient, patient starts moving or shaking. As you show in the as it was demonstrated in the video, my assistant was compressing on the patient. while I was injecting the cement to achieve a position. Disease, and we did a cementing very nicely. Patient was pain free. This is another patient where there is two-level compression fracture. Now here the challenge would come that what to do about the intervening segment of the vertebra. I always prefer to fuse this kind of vertebra so that the adjoining level doesn't compress eventually. This video demonstrated that cement was injected into the two fractured vertebra, and the intervening vertebra was also cemented to prevent compression fracture happening at that particular level, particularly when you have injected cement level above and below. Now this we call it a Teletubby sign. This happens when you withdraw needle too prematurely, and sometimes this cement comes back into the pedicle. Ideally, it is of no consequences, but try to avoid as much as possible so that your cement is well confined into the vertebral body. Now, this is the post-op X-ray of the same patient. You can see that this Teletubby sign is still visible, but overall patient did very well. This is another patient with compression fracture. You can see that patient is having a compression fracture, but when patient was made on a loading X-ray, you can see that patient was going almost into vertebra plana. Now that is one sign that your patient is having intravertebral instability. We had to do a open vertebral. This is our old patient. Now no longer we do an open vertebroplasty, but just for the completion of purpose, I have put this case. So this was because patient was having significant intravertebral collapse under loading. We decided to fix this patient with 2 level above and 2 level below long segment fixation. As you can see, this is the index level cementing, and 2 level above, 2 level below non-cemented screws. Now when you're here, just to prevent proximal junctional failure and distal junctional failure in a long segment in osteoporotic spine, I particularly prefer to put cement so that the adjacent level doesn't fracture eventually. Again, this is a very old patient, and we have stopped doing open vertebroplasties or open fixation for this kind of a patient.
Niraj, can I ask you one question?
Now, what we do in today's time, whenever we have...
So you're showing that you topped up your fixation with cement fixation. Do you now routinely augment the superior most screw with cement when you're doing it, say, percutaneously? So I guess or even
that open? I'm taking in later part of that video. I've actually stopped doing long segments. We recently published our around 75 cases with short segment cement augmented all level with index level screw fixations, and that has stood the time of. I have 2 years follow up with them, and we had 1 or 2 failures, but I guess majority of them. So we have stopped doing long segment. We only do short segment fixations now.
Your take on that?
I have a question. When the planus vertebra like this, do you consider putting in doing a balloon or a kyphoplasty?
Well, I guess I was one of the probably say that initial adopters of kyphoplasty way back in 2008-9. I don't remember I have done kyphoplasty after 2013. I personally had in my hands, I feel that it's of no use to my patients. I think, I'm happy doing a positional reduction. Majority of these patients are fragile. If you just stabilize them, they are pretty happy. Literature also probably, now has started saying that, kyphoplasty is to prevent cement leaks rather than, the height restoration or kyphosis correction, because it majorly happens during positional reduction. So I think I have more or less stopped doing kyphoplasty.
Thank you.
And osteoporotic vertebral compression fracture with intravertebral instability, as you can see this in this patient, where you can see this complete collapse has happened, and when patient is made to lie supine, it is opening up. So we consider this is a significant intravertebral instability. If you do an isolated cementing, there are higher chances that you will have a peri-cement fracture and a failed vertebroplasty. And in this kind of patients, we prefer to use a fixation along with a cemented screw or a non-cemented screw, as you can very easily see in this particular patient. That you can see that this was a patient where we had put an index lever screw, one screw above, one screw below. This was a non-cemented screw. We first did vertebroplasty, then over guide wire we inserted the screws. And traditionally we inserted one level above, one level below, considering a short segment fusion. This was another patient which has a post-traumatic osteoporotic fracture. We did a cemented augmentation without putting an index screw. We have stopped using this technique of without putting index screw in all of our patients whenever we are doing a short segment fusion in intravertebral instability. This was another patient where we had put a cemented screw long back. Then patient comes with DJK and we had done a cementing. Then eventually third time patient comes with one PJK, and fourth time with two above PJFs in our patient, and we had to cement at all the places. And this is the fourth X-ray where we have done classical all cement augmented screws, as you can see in the. Here is the case where previously vertebroplasty was done. Patient still went on complaining about significant pain. When patient presented to us, patient has a peri-cement mental fracture. As you can see in this video, there is a lucency. There is a lucency visible around the cement. And patient was having significant pain and disabilities without neurology. We decided to do a percutaneous cement augmented screws. First, we always put all screws in AP on one side, then all screws in AP on the other side, and then it was decided to needle the index fractured vertebra, as it would be visible in the video in a short while. We follow the standard technique of percutaneous screw injection. Make sure before injecting cement from the cannulated screw that a guide wire is passing through all along, so that you are sure that your screws are not clogged by any bone pieces or any blood clot, and cement flows without any resistance from the screw. So this was a long segment because it was a failed vertebroplasty. We no longer do long segment for primary vertebroplasties. As you will be able to see that when we started injecting needle into the fractured vertebra, the moment needle entered into the fracture, you can see that it opened up. We were into double mind in this particular patient whether to put screw here or not, but considering the previous cement, we decided just to inject the vertebra with cement and stabilize with a long segment 2 level and 2 level above and 2 level below fixation. Finally, the rod was inserted percutaneously and it was attached with the rod and fixed with the inner screw, and you can see this was the final X-ray for the patient. We had ruled out infection in this particular patient as a cause of cement loosening. This was just a peri-cement mental fracture, nothing else. Sometimes we do a stent plasty also whenever we find there is an intravertebral instability. As you can see, this patient was already operated with a cement augmented fixation. Patient had an adjacent level fracture, then again adjacent level fracture. So we used this stent as a stentoplasty to internally stabilize the vertebra, and then we augmented it with the cement. This was the adjacent level or the one level above cementing just to prevent the collapse of the adjacent
Niraj.
level. To summarize, painful osteoporotic.
So, where would you strongly recommend using stentoplasty, pure just vertebroplasty, and kyphoplasty, and why?
Well, I have very limited experience of stentoplasty because I only inserted 7 stents from debut, and then DePuy is withdrawn from the country. So far I only have 7 patients experience. So I really, I guess, I was hoping that, maybe it can be inserted into patients where there is an intravertebral instability, where, internal scaffold is stabilizing and, will prevent cement mental fracture. So that was my original thought process about using stentoplasty. I'm not sure whether any company is available which provides or not.
In Singapore, what are your indications of doing this stentoplasty, vertebroplasty, and kyphoplasty?
So in Singapore also J&J has pulled out. We were using some stents. There was this other stent like a jack, but that also has been withdrawn. Smith and Nephew.
Yeah.
So that has also been withdrawn. So I personally do not have much experience as well with the stents. Yeah.
So just to add that in Nottingham, we used to do a lot of vertebral body stenting, but we used to mainly use it for metastatic fractures, myelomas, etc. But we should never use it for osteoporotic fractures, because in osteoporotic fractures we had experience where in trying to jack it up, we used to have more fractures because the bone is so osteoporotic.
Yeah.
So for myelomas, metastasis, etc., it had worked
No, I
quite
guess
well.
my indications to use stent was different. I think it was Kumel signs where there is already an intravertebral instability. There is a deep void already there. So we wanted to internally provide a scaffold over which in between which you can inject the cement. And my thought process was that it will prevent a collapse or a fracture around the cement mantle, which happened in one of our patients, which I had demonstrated. So that was the thought process. That's why I think 7 patients which I use, they have pretty good outcome. But it's very difficult to comment on just 7 patients that good, bad, or anything.
Thank you.
Just one question. So now you don't do the long segment fixations anymore. You switch them all to short with fracture site index screw.
Yeah.
And the experience has been good.
Yes.
So do you do your index screw, your vertebroplasty through the index screw, or you use a separate?
Yeah, no, through the screws.
Through the
screws. In fact, if there is no Kumel sign, we rarely put screws nowadays. But say, for example, if, there is a stable segment and for whatever reason, maybe you have a burst fracture, you feel that cement would leak and you really want to fix it. In those cases, in fact, I have put classically what we do in thoracic lumbar fracture, very short screws and injected cement with a needle just to provide interior support.
Okay. Thank you. Can you summarize, please? Sorry.
Vertebral compression fractures are amenable to vertebroplasty or cement augmentation. It has to be T1 hypo and stir positive fracture. If there is an intravertebral instability, you have to go and hunt for it. About 3 to 4 cc of cement is adequate in our patients. Single or double needle technique as per the preference can be used. I always prefer a single level needling technique. Try to achieve positional reduction before injecting cement. You won't need kyphoplasty. Inject the cement at absolutely right consistency. The moment cement enters posterior 1/3 of the vertebra, stop. Do not inject any cement further. Hunt for this intravertebral instability by checking dynamic films, supine and loading x-rays. If your patient is not able to stand, then your sitting x-ray would also be sufficient. If present, short segment fixation with or without augmented screws with at least one index level screws provides adequate stability. We have published our paper and submitted into JMIST. So short segment gives equally good outcome as long segment, and you really don't need to go for long segment in all the patients. Thank you very much.
So